So thank you, Michalis. And still to be optimistic, we have to remember that during these 100 years that the improvements are so few. We are talking about 85 to 90% satisfied patients. And this is very important. We want to improve in these results. Because practically what we want as clinicians is to have satisfied patients. So, from a functional point of view, the rotator cuff is dynamic stabilizer of the shoulder. And there are those couple forces that they are very important because they regulate the motion of the shoulder. And rotator cuff is not just one muscle or one tendon, it's a functional unit. And as such, we have to see it. It's a different perspective. So what is happening is that we have a combined harmonious function of the deltoid, the periscapular muscles, all the body core muscles, and the rotator cuff muscles, and so the arm can be moved without pain. And there is a synchronous and sequential motion activation of the muscles. And this is a muscle activation pattern. This is what we want to restore, a muscle activation pattern that is going to raise the arm in the most efficient way, with the less energy consumption. And injury disturbs these muscle patterns. That is what is happening. So this is what we want to restore. And there are many different activation muscle patterns that they can raise the arm. The body strives to find the way to do what it's called to do with the most efficient way and less energy consumption. And by strengthening the muscles, we can improve their power. We can do muscle transfer, we can repair the tendons, but just strengthening, we can improve this muscle power. And if we can find a way to have the patient able to strengthen without pain, then we have done a step forward. The second is that raising the arm is a skill, it's a motor skill. And motor skills are learned by repetition. So if we can have conscious, self-observed repetition, then we can regain the motion. And that is the role of physiotherapy. Physiotherapy as a conservative treatment or as a treatment, as a rehabilitation after anything we have done in surgery is very important, and that is what he is doing. We are relearning skills that we lost, or we establish new skills if the injury cannot heal, it's irreparable. So what we try to do and what we are discussing here is to create an anatomic environment that can allow the development of muscle patterns of least energy consumption. And if we can do this, then we can regain quicker the function. If we can regain quicker the function, we need a patient that is less motivated. If he has to repeat exercise for a long period, he needs more motivation. This is what we are trying to do. We are trying to change the anatomy in order to do the regaining of function easier. So, what we try to restore the equilibrium between the energy demands of the patient and the capacity of the rotator cuff, not only the rotator cuff or the muscle around the shoulder to respond to these demands. And if this happens, we have a satisfied patient. If this does not happen, whatever we measure objectively, we have a dissatisfied patient. And the four scapes that we have talked, they were described by Burkhardt, and it is still the center of what we are doing. And this is the superior, in the frontal plane, the four scapula, between the superior deltoid and the inferior cuff. And of course, the couple in the transverse plane between the subscapularis and the infraspinatus και teres minor. We have discussed them too much. And we know that if these four scapulae are disturbed, then we have pseudoparalysis. Whatever we say is pseudoparalysis is, if the four scapulae are disturbed and we cannot restore them, the shoulder cannot function. So, a torn rotator cuff with functioning force couples is a functioning rotator cuff. The patient may have pain, but he's still functioning. This is a stable fulcrum kinematic. This is from the 90s and from a charismatic surgeon, Steve Burkhardt. But there is another way of the shoulder functioning. If the head is captured under the acromion, then we have a capsured fulcrum and still the shoulder functions. And we see a lot of patients that they have a massive rotator cuff here that has a superior migrated head and still they are not having symptoms or they have very few symptoms. And of course, it is the anterosuperior escape and then nothing can function and then reverse shoulder arthroplasty must happen. And then this description from Colin and Matsumola, Landerman, Valls, this very interesting concept of the 5 components of the rotator cuff. And what we knew intuitively and what we learned by their paper is that all the rotator cuff tears are not the same, and where is the rotator cuff? It's not only the size, but where it is very important of what is going to happen. And B, C, and E were the types that were most disabling, and type B is notorious 80% pseudoparalytic shoulders. The question is that less 20%, how they are functioning. What is happening to this 20%? And of course, in type E tears, where we have complete loss of external rotation when we have lost all the rotators. So, when we were surgeons and when we say, okay, we have an injury, we have an injured cuff, what we have to do, we have to restore the anatomy. This is the first thing that we are trying to do. The question is, if this is not possible, what we can do to restore function? And this again, the classification of Davidson and Burkhardt again gave us some way to navigate, knowing that the type 1 and type 2 tears, we can expect a very good result by repairing the cuff. Type 4 tears, we need cuff tear arthropathy, reverse shoulder arthroplasty is the solution. And then these massive contracted tears that we start to try to understand what to do. So, in type 1 tears, what we want? We want balanced force couples, we want strong fixation, we want repair without tension. If we do any repair with tension, the repair is going to fail. And the components of strong fixation, the tendon, the suture, the anchor, the knot, the bone, and all this is that under our control and we can change in many ways. And we have to remember, the problem is where is the problem in a chain is where is the weakest link. We have to take this out in order to have a satisfied repair. So we know and we heard the age of the patient is very important. Most important is the chronicity of the tear, the duration of the symptoms. Of course, fatty infiltration, patent tendon retraction, all these are things that we take into consideration. And we must remember that sometimes you have to restore function rather than anatomy. And this has to do with the fact that if we try to restore anatomy, most of the time you have a period of immobility that is needed for healing. And this period disrupts all the muscle activation patterns. And we know it from fracture surgery, and now we have to apply it also to tendon surgery. Sometimes it's better to stop trying to repair. And Valls and Boileau and many others published papers and noticed that the fact simple tenotomy, debridement, can have a good result in these types of tear that still have functional couples, muscle couples. And we talk about this, all this, and how we can increase the functional capacity, physiotherapy. But we need to have a very good communication with the physiotherapist, and we must try to explain to them what we want them to do. And they have to do two things. One is to learn the skills to the patient, to increase his strength, to learn the new muscle pattern first, and then keep them motivated to do it. Then, in space balloon is a similar idea. We can change the strength of the muscle by either increasing his power or changing the level arms. And balloon, superior capsule construction, try to change these level arms and so change the game. This is our so tendon transfers, we talk a lot about them. And the other point is something that was stressed by Dr. Adeli, enhancing the biology, how we can do it. And we know that we have local intervention, PRP, mesenchymal stem cells, all this. Local intervention, microfracture, easy, cheap, quick, and we have to do it. Ventitankers, we have now ventitankers that allow mesenchymal stem cell from bone to get to the environment, to the subacromial space, microfracture, and also transosseous repairs. So, next, what we can is PRP. We don't know a lot about PRP. There are so many types of PRPs. But what we know is that we want a lot of platelets, and so we have to take enough amount of blood. We have to centrifuge it at least twice, use large tubings in order to not to have primary early activation of the platelets, and in this way try to do the best with this PRP. Bone marrow derived mesenchymal stem cell is something that we try to use, and it's like the adipose stem cells, stroma cells, but we are more familiar with bone marrow as orthopedic surgeons, and we know that this is affected by the age of the patient and the donor of the stem cells. So we try to calculate from different sides, anterior iliac spine, posterior iliac spine, the tibia, and we show that posterior iliac spine has more the same red cells, more nucleate cells, more colony-forming unit. That is all I know from microbiology, stem cell cultures and all this. But what it is, there is differences even from the where we take the stem cells. And seems posterior iliac crest is a very easy way to get stem cells and use it during surgery. And then it is those scaffolds. We have to remember and that when we try to use something, it's two things that we have to take into consideration. First, the effectiveness, and second, the cost. And this equilibrium between cost effectiveness, we can change either by increasing the effectiveness, if we can do it, or by lowering the cost. So by lowering the cost, we can use it more times, have a better pool of patients, a larger pool of patients, get results, and increase our knowledge. And this is one bioanti-inductive collagen pass. We talked about this. Is the Gen 10 that we used. And we changed the leader technique in order to make it easier to implant and make it cheaper also. We avoid the anchors for the bone. We don't see why we have to stabilize this in the bone. And also, we don't want it as a mechanical support, we want it as a biologic support. And we have done 19 patients till now, and we try to gather results and see if they are, we have any better clinical results in this case series. And it seems to be good results, but we know the difficulties. What is interesting is what we see with, that's the one we got, yes. What we see when we have second look arthroscopy, and this is what we see with the nanoscope, needle arthroscopy. And it is really impressive when we see this 6 months after the operation. And it's no inflammation, a very well healed calf, no signs of the implants that the anchors that were stabilizing the implant onto the repair. And this is the patient 6 months after the operation. So, partial complete repair, tendon transfer, grafting, all this, and at the end, reverse shoulder arthroplasty. Now we have a lot of solutions that 15 years ago we didn't have. So in conclusion, we don't have a problem with the small and medium-sized rotator cuff tears. Practically, we have found the solution. In the large, the massive tears, this is the treatment challenge still. And this is where we are improving, this is where we're thinking, this is where we exchange opinions of what to do. And now we have a lot of viable treatment options with very good results, and additional biologic augmentation is very promising now. So thank you for your attention, and thank you for being here.